chronic. So if you think about someone with compensated cirrhosis or uncompensated, there are abnormalities. In compensated cirrhosis, the intrahepatic vascular resistance is increased, and there's moderate portal hypertension usually, and some splanchnic arterial vasodilation, and low effective arterial blood volume. If the person is compensated, one way to look at it is that this person will increase cardiac output, will be able to some extent increase plasma volume, and will then restore effective arterial blood volume and not be in trouble. On the other hand, when someone is decompensated with disease progression or severe portal hypertension, there may be bacterial translocation from the gut, there may be infection, and splanchnic vasodilatation becomes more marked. This will lead to a markedly reduced effective arterial blood volume. Increased cardiac output may occur, but plasma volume won't be sufficient to normalize, and then various sodium retaining and vasoconstrictor systems will come into play. Sodium and water retention in the kidney will occur, and by other means as well, of getting salt and water into the vascular system. There may be leakage with this whole situation and ascites, further activation of the vasoconstrictor system, impaired cardiac output, and kidney failure, sometimes acute on chronic. It goes without saying that, I'm trying to change how this looks, that when looking at somebody with liver failure, kidney function needs to be looked at. And I think you all know this. You follow the serum or plasma creatinine, depending on how you measure it. You follow serum sodium and potassium concentrations. If there's acute kidney failure, at least once a day, or it may be even more. And various electrolytes and protein levels should be measured in the urine and in the plasma. Maybe kidney ultrasound will be done to rule out obstruction, but the ultrasonographic appearance of the kidney usually is pretty normal in most cases of cirrhosis with kidney failure, but abnormal kidney sonograms indicate maybe there's also chronic parenchymal renal disease, but vascular studies may indicate decreased flow to the kidney. Sometimes kidney biopsies can be helpful to rule out something else. And then, of course, hepatic function needs to be followed, as you know, as well as assessment of bacterial infection. And although this is an old slide, these things still pertain. If one then thinks about, okay, kidney function is decreased, the usual list does not always include bile nephropathy. Hepatorenal syndrome may be diagnosed on the basis of an elevated creatinine level, which doesn't change when you give albumin. Some people will do that in the absence of shock. There's two types that are now classified. Sometimes they're called type 1 and type 2, but type 1 is more chronic. Type 1 is more acute, and type 2 is stable and less rapidly progressive. Maybe it's just prerenal hypovolemia-induced renal failure. There can be parenchymal renal disease or drug-induced renal failure, or there can be a metabolic problem as well, and a long list. But when you think about bile nephropathy, jaundiced patients have an increased risk of kidney failure, and if it occurs, the prognosis isn't good. You know this. One thing to think about is there are an awful lot of names for this entity, which might suggest that people don't really know what it is, or that there are many people trying to figure out what it is from other points of view. It's been called cholemic nephropathy, bile cast nephropathy, bile nephropathy, bile acid nephropathy, icteric nephrosis. And I think the spread of names indicates a lack of consensus. Is it specific? Well, you could say, okay, it's a specific type of acute kidney injury. It occurs in people with liver injury and associated hyperbilirubinemia. There are typical and specific findings on biopsy. There's kidney tubular injury and formation of bile-containing casts. If we back up and think about hepatorenal syndrome and look at its history and think about bile nephropathy as part of it, that gets us maybe somewhere. These are old micrographs or photos of bile stones and casts in the kidney. And this is from basically 160 years ago. This is from jaundice in the kidneys of a middle-aged guy with cancer in the head of the pancreas. And what it shows is that it's been known for a long time, probably longer than this, that there's bile staining in kidney tissue. The other way to think about it is, how often has the term hepatorenal syndrome been used? And how long have people talked about bile nephrosis? Well, in the 20th century, bile nephrosis was mentioned relatively frequently compared to now in various books and articles. And what you can see is HRS, or hepatorenal syndrome, came into use and was mentioned more in the 1930s, and its use has gone up. But the mention of bile nephrosis or bile nephropathy has really not been mentioned very much. And I would say, when I saw this in different ways in a variety of articles and on the net, I talked to a number of my colleagues who see patients with liver failure frequently, some transplant nephrologists and hepatologists, and they said, well, is it really something? Isn't it just that there's bile casts in the kidney, but you've got to move on and do other things? So I will talk about both a little bit, and then talk about bile nephropathy and should we think about treating it, and would thinking about it and treating it improve the outcome of other things. So this is a compound slide. I did not put it together. And what you can see is that the central part is by the very well-known Frank Netter, who was in his ascendancy, if not pinnacle, long ago when I was a medical student. So what you see here is his concept of hepatorenal syndrome, with acute things like GI bleeding from varices or an ulcer, being set off also by excessive or perhaps injudicious paracentesis, overly vigorous diuresis, someone who's icteric, has 10 ascites, becomes oliguric, and mortality when this occurs and renal failure progressively occurs is going to result in a 95% or greater mortality death within 3 weeks after onset of azotemia. We know more about this now, as you know. We know that various cytokines and inflammation are elevated, that there can be bacterial translocation and endotoxemia. Metabolomics have showed a number of things, and there can be various levels of acute kidney injury. And as I mentioned before, type 1 and type 2 HRS, with type 1 being acute. We also know that there are endocrine systems involved, including responses of hormonal systems like the renin-angiotensin-aldosterone system, ADH, various lipid autocoids, and the adrenal cardiomyopathy may occur with this. And here in this current look at it, colic nephropathy may occur. And so in current thinking still, hepatorenal syndrome is involved with what happens in colic nephropathy. The differential diagnosis is variable, but in this way of looking at it, what one can see is that the prevalence of hepatorenal syndrome is less than that of acute kidney injury or prerenal injury. I think that you all know and look at urine to plasma osmolality, and in hepatorenal syndrome, the osmolality is greater than 1. In ep.10 or AKI, whichever way you want to call it, urine and plasma osmolality are essentially similar. And in prerenal azotemia, there is a higher urinosum. Urine sodium can help you in concert with this, and the UP creatinine ratio also is helpful. And it has been said that in pure hepatorenal syndrome, the sediment is usually normal, but since other entities can accompany it, not necessarily. Well, what about bile nephropathy, which I'll focus on for the rest of the time I chat with you? It's known that bile itself can lead to natriuresis and diuresis. A number of animal models will show this, and that there are hemodynamic changes that are induced by endotoxins that are portal and systemic, and that there can be direct kidney damage based on histology. Historically, there are an awful lot of liver diseases associated with bile nephropathy, not just hepatorenal syndrome. Stones in the common bile duct are a pure cause. Various malignancies, lymphomas, and solid organ tumors have been associated with it. Primary sclerosing cholangitis has, as has acute hepatitis or acute chronic hepatitis being pretty frequent in Asia. Drug-induced hepatotoxicity has been, and various infections such as severe mononucleosis and malaria. And there have been a number of cases complicating type 1 diabetes. One of the problems, or at least as a nephrologist, I find it so, about thinking about bile nephropathy is that in the last several decades, most of what is quote unquote out there consists of cases and case series, not so much a study, and almost no trials that I could find looking at treatment, and certainly randomized therapy maybe even less common. So there are a number of factors that those who think about it would say leads to bile nephropathy. Various molecular substances that cause damage to the kidneys are there: vasoconstriction, pathogen-associated molecular patterns or PAMPs, volume depletion, drugs, bile acids, and bilirubin. All of this may lead to acute kidney injury in jaundiced patients. So while it ought to be something that is intuitive, if one concentrates on biliary constituents, i.e. bilirubin and bile acids, it might be misleading, because if you just think about that, it's just because of jaundice and very increased bilirubin and bile acids. It omits the inflammatory processes that probably do play a large role. And if one sees it as an individual entity, might be something to treat. The other thing is, and you may all know this well, but I did not, is that in chronic bile duct ligation model, bilirubin can have some renoprotective effects. It induces heme oxygenase 1, which is an antioxidant and anti-apoptotic compound that interacts with a number of systems that would actually be renoprotective. And it can improve vascular resistance, at least in mice, rats, and dogs with chronic biliary duct ligation. It actually can improve kidney tubular function. And in terms of pathology and EM, it may improve mitochondrial integrity, and it may inhibit reactive oxygen species in NADPH. The kidneys normally do help regulate the bile acid pool, as I'm sure you know. About 10%, but up to 50% of bile resorbed in the enterohepatic processes escapes extraction in the liver, and the spillover is filtered by glomeruli. But obviously, if there's high bilirubin, more is going to be filtered by the kidneys. So if you look at this model, which, and all models are cartoons like this, have a lot of experiments behind them, but are a best guess. And this is one take from Crohn's et al. From Austria, which is that in the liver, with increased bile acids, the hepatocytes are going to seek alternative exporting means. For example, with organic solute transporter, alpha and beta, and with the multi-drug resistant proteins 3 and 4. In this case, the example being biliary obstruction. So there'll be more bile and bile acids, and these will get to the proximal tubule, where there will be uptake, and that can be toxic, but there can also be export. So the atypical sodium-dependent bile acid transporter gets downregulated as much as possible, but does not get fully downregulated. So there's still a lot of uptake. To try to get rid of the excess bile acids, the multi-drug resistance proteins 2, 3, and 4 are increased. And perhaps this helps, but it doesn't prevent the entity for continuing. Usually bile nephropathy occurs in an acute on chronic situation, but as I mentioned before, there are precipitating events that are common, as you saw in the expanded Frank Netter story. There are large dose diuretics that may be given to try to mobilize fluid. Maybe large volume paracentesis needs to be done. Maybe the patient has developed a big GI bleed or is septic. All of these may convert a prerenal acute kidney injury to hepatorenal syndrome on top of bile nephropathy that is there. Well, in advanced kidney disease, as I said earlier, kidney function is prognostic. And what about bile itself? It will affect urinary concentration and dilution, and bile conjugates themselves may have effects on mitochondria separate from bilirubin itself, and these can be toxic. Bile acids that are hydrophobic are particularly cytotoxic, and bile acids can inhibit oxidative phosphorylation, decrease ATP activity, and also can change cell membrane permeability. And as I said before, bile can be renoprotective, as I mentioned. Histologic studies will support or not support that this is just an entity that's part of hepatorenal syndrome. You probably know the work of I don't know how you say his name, Slambrook. What he and his colleagues did was to look at a series of 44 people in whom there was histology done. And these were persons who were felt probably to have bile nephropathy. So what you can see in this series, and none of the series I've seen are large, bile casts were present in 55%, about a little more than half. And the bulk of the patients, close to 40, 60, were male. In this particular study in the US, African Americans predominated more than the number of African Americans we have in the population. And as you know, persons of color have a higher risk of advanced kidney disease and are disproportionately affected. But the other thing that one can see in this series is it probably reflected referral because Hispanics also have a high likelihood of having kidney disease in this setting, and they had only overall 9% who were Hispanic. And what you can see in this table 1 is that the group of investigators looked at, were there bile casts or not? And as you go down this table, what you can see is that when there was hepatorenal syndrome, 85% of those who were looked at, and there were only 13 with hepatorenal syndrome, 85% of them had casts. So it's hard to separate things out. If you also look at other entities, one could see that bile casts were present in 100% of those who were highly jaundiced and in all of those who had cirrhosis due to ethanol. The clinical data overall showed that if you look at table 2, bile casts were more likely to be present with a slightly higher serum creatinine, but this wasn't significant. And although the authors made something of this, I don't think a statistician would. So this is simply a look which tells me anyway that while certainly one can have bile casts without hepatorenal syndrome, with hepatorenal syndrome, they're present. Various bile acids, and you folks know this pathway, or actually pathways, because there's the classic pathway and the alternative pathway, leads generally to colic acid and chenodeoxycholic acid. But some of the other compounds can be toxic to the kidney, which is the only point I want to make with this slide. One of the things to think about, and I think one of the best things to think about as to whether there is or is not, as an independent entity, bile nephropathy, is to think about, are there bile acid pathway components that could be targeted? And those who do research in the area have looked at the farnesyl X receptor and found that perhaps inhibiting it would regulate genes that might ameliorate bile acid nephropathy. How does it start? And pathologically, in the kidney, it appears that the collecting duct is most often where the first changes are seen. And then one begins to see damage, if you look at the middle cartoon, is seen in various tubular cells. And ultimately, bile casts will be formed, and over time, a variety of compounds and cytokines and cells will migrate in, and there's a tubular or interstitial disease, which can be profound and could lead to chronic damage. Here in this slide, and sorry, I did not have any that I could get from our pathology department, you can see casts in the tubules, which in this PAS slide are not obviously stained. But in the series from Van Slambroek, you can see a number of casts that clearly are bile stained. And in the case of some of these tubules, there is a great, as you can see better here, I think you can see my arrow. It's the upper right panel, a tubule that's very damaged, and you can see that also underneath it. Are there markers that would tell us that somebody has a component of bile acid nephropathy? Well, there are, and most of them come from bile duct ligation studies. And the biomarkers, unfortunately, are not really pathognomonic, but investigators have looked at NGAL, which is upregulated, looked at KIM1, and have looked at IL-18, and the origin of these markers are noted here. We know that NGAL and KIM1 are tubular markers, and that IL-18 is obviously an inflammatory marker, and it can be found in the plasma or serum and urine, and its origin is from monocytes and dendritic cells, macrophages, epithelial cells, not just in the kidney tubule, but in the intestinal epithelium. LFAB is produced in the liver and intestine, but also directly in the proximal tubule. And in the end, a good thing to do is look at the urine. And all of the tubular markers, NGAL, KIM1, have been found in the mouse model, both as protein and increased mRNA expression. And in looking at urine, one sees bile-stained casts that may contain leukocytes or leukocytes with inclusion bodies that include crystalline bilirubin in some case reports. So I'd like now to talk for a bit about what is known about therapy of bile nephropathy. The quick answer is not much. Supportive care is of course important, and it is very important to have collaboration between hepatologists and nephrologists and do what's necessary to support the patient. And because of the vascular abnormalities in terms of vasoconstriction and instability, often an ongoing form of renal replacement therapy will be better than dialysis. And people do debate that. A number of things seem to improve, mostly models of bile nephropathy. A hydrophilic side chain modified ursodeoxycholic acid therapy, nor UCDA, has seemed to be helpful in animal models. Milk thistle has also been used, or Salimarin. The Salimarin is a common thistle that I see around New England all the time, and I'm sure you see in the mountains where you are. It's been in use for 2,000 years. So it has definitely got a long history. People used it before the modern era for liver, kidney, and gallbladder problems. And there are a number of studies that have found that probably the most active substance in milk thistle is a flavonoid, the one that's called Salimarin, and it does seem in some studies to protect the liver from toxins, including acetaminophen, and is widely used by people who believe in herbal approaches. It does have antioxidant and anti-inflammatory properties and may help the liver repair itself by regeneration. There are some other things I will talk about listed here: odevixibat, colic acid, sulfasalazine, a Chinese herbal decoction called Huangqi, HQD, amino forms of penicillins, perhaps, and interestingly, the use of Ivacaftor in conditions of bile salt transport mutations. Odevixibat is a reversible inhibitor, shown here in the lower right corner, of the ileal bile acid transporter, or IBAT, and it decreases resorption of bile acids from the small intestines. It has been used to treat congenital cholestasis, and it may treat or prevent bile nephropathy. I have not seen, and maybe you have, we can talk about it, treatments in people with this agent, but there's certainly talk about doing so. In an animal model, inhibiting NF-kappa B and the inflammatory response has been widely thought to be a good strategy to blunt the bile acid-induced kidney toxicity and also hepatic toxicity. So there's been a recent study by Amati and colleagues, looking at a bile duct ligation model and using sulfasalazine in 10 and 100 milligrams per kilo to inhibit NF kappa B signaling. So this is, in this very recent study, what the authors are trying to do. What you can see is they've created their bile duct ligation in a mouse, and they're saying, okay, there's cytotoxic bile components that are increasing in this animal model. That leads to oxidative stress and impaired mitochondrial function. Gut permeabilization also occurs. And then they've got here the nasty ultimate conclusion pathologically of hepatic and renal inflammation. With this, there are cytokine releases, and what they are thinking within the nucleus you could do is that sulfasalazine acts here and then releases components that can bind to DNA and cause less inflammation. They do back it up in their model with a change in a number of things that you can see here. If you look at ROS formation, and what you can see is the white bar is sham-operated animals of control. The bile duct ligation is the color of liver, at least on my screen, and then the 2 doses of sulfasalazine. What you can see in each case, 3, 7, and 14 days after the procedure, that ROS formation progressively goes up, but it is reduced towards normal even at 14 days in the animals which got SSLZ. Protein carbonylation also goes way up after bile duct operation, and it goes down to normal in animals given sulfasalazine. Same with antioxidant capacity, and same with tissue lipid peroxidation. So they conclude this is promising, and as this is an agent that is available, maybe some clinical studies would make sense, and I'm sure they're working towards that. What about Ivacaftor, as you know, used in cystic fibrosis, but mutations in ABCB11 or BSEP predisposed to several liver disorders. Most of them are severe, progressive familial intrahepatic cholestasis type 2, and over half of such patients don't do well, and many of them, as you know, go to liver transplant. So the study that I'm showing here is in vitro and used the PT4631 mutation of PSEP, and it had been identified in a patient who had a defective canalicular bile transport. And this is totally done in cells, but Ivacaftor rescued the defect in a dish. This is very new. But the thought is maybe Ivacaftor might constitute an efficient targeted pharmacotherapy for some selected patients with this mutation, and maybe it would prevent bile acid nephropathy. What about Colic Acid? Inborn errors of bile acid synthesis, as you know, will lead to production and accumulation of atypical bile acids and bile acid intermediates and reduced amounts of primary bile acid So maybe colic acid treatment itself would improve bile acid excretion by the kidney and bring the abnormal metabolites along with it, as well as various aminotransferases that increase and would improve the edema and anasarca in patients with bile synthesis disorders. It appeared in using this in some patients in a short, small, recent study that it appeared to be safe and effective, quote unquote, over the long term. And I have not and could not find that the EMA or the FDA approved colic acid for the use in these disorders, but a phase 3 open label study is presently being done. So is bile acid nephropathy interacting with hepatorenal syndrome? I think yes, they do occur at the same time, but not necessarily. And as you can see in various conceptions of what might be happening, is that when there's portal hypertension and liver failure, there are a number of things with direct damage amplifying compounds that may activate innate host immunity and release toxic substances, and these may lead to hepatorenal syndrome, but at the same time, many of these same things will lead to a bile nephropathy component. So there are really two camps as far as I could tell, and people have written strong opinions. View one, which is, I think, after my thinking about it and talking with people, a bystander phenomenon in patients with hepatorenal syndrome and sometimes occurring on its own. And in support of that is the fact that one really does see evidence of this entity within people who have not done well with hepatorenal syndrome. And most of the data about that are from autopsies, frankly, not biopsies along the way. The other view is that it can be independent and may be additive. And I did go over much of the findings of Van Slambroek and colleagues. So that is where I'm ending with it, because I'd really like to get your input. And also, if anyone wants to talk with me or write to me, I'm easy to find. An unusual last name and nejm.org is not hard. So I'm going to, at this point, stop my screen sharing so I can see you and ask if you have any questions. Thank you.
Thank you very much. It was very informative, very challenging, and very brainstorming. So I open the discussion. There's any question? Is anyone willing to interfere? Or
I see that before Vitek.
Okay, Liver, go ahead. Liver?
I think I'm not hearing you.
Can you hear me now? Can you hear me now?
You.
Liver, you're.
I'm not hearing Libor.
Liver? Liver? No way.
And now?
Yes.
Yeah.
Good, good, good. Fine. So thank you very much, Julia. It was very inspirative. So I have several comments, if I may. I'd
Please.
like to emphasize that mildly elevated serum bilirubin levels are in general viewed as protective, renal protective factor. It's known from the Gilbert syndrome studies. It's known that it's protected against diabetic nephropathy and many other things. We also have old studies published in 70s that hyperbilirubinemic gun rats have really bilirubin nephropathy, which is believed to be caused by precipitation of bilirubin in the renal medulla. But to my knowledge, there is no such clinical study on either severely jaundiced neonates or Crigler-Najjar syndrome patients. And I also wanted to mention that it seems that better therapy than colic acid might be nor-ursodeoxycholic acid, at least based on the paper published 4 years ago by Michael Trauner's group, which is much more polar than colic acid. And it's, let's say, not believed, but it has been suggested that it might be a future of this bile induced nephropathy. So these are my comments. If you could just say a few words on that.
I think that I did mention the ursodeoxycholic acid, but I have not with any of these seen large studies, and that's a problem. I think an issue is, for me, is there something out there that's been studied enough so that it could be used preemptively, and would it help? And that's for young people in the field to get studies going. I guess the question I have for you, going the other way, back to you, Libor, Claudio, and all of you, Francesco, is when you suspect a patient has a component of bile acid nephropathy, what do you do besides supportive care?
So it's just a question of the primary cause, which is the liver disease, because you need to just do anything with the liver disease, with the cholestasis, and then you may be successful, otherwise not. Because from my point of view, bile acids are the culprit. And if you do not do anything with cholestasis, you have no chance. So maybe back to the urso. So it's believed in hepatology that this is the drug of future. It has been shown, at least for primary sclerosing cholangitis, that it's really something very promising. And I think that the people focus on the research of this drug are convinced that it will have also some further consequences in terms of treatment of diseases such as this. So.
Well, thank you.
Well, may I make a comment? I mean, I think that in the scenario you so elegantly presented, there are three major actors. One is conjugated bilirubin, the second is unconjugated bilirubin, and the third are bile acids. And I think that the key issue is who is playing the major role, if there is any major actor. I think there's a sort of cascade. And actually, if you look in what has been demonstrated in vitro and in vivo, for instance, unconjugated bilirubin has a lot of effects on the cell metabolism. Actually, bilirubin has been shown to be a very active player with the PPRK effectors. So I think that we need to understand who is coming first, if there is someone coming first. As far as bile acid is concerned, as Libor said, we have a nor-urso now on scene. but we can also have a very old way to reduce the load of bile acid by providing the gut of the patient with some absorbing compound like cholesterol. This is able to reduce the bile acid concentration in the short run. In the long run, it's invisible because the side effect it's rather high. So I think we need to think about how to deal with this dramatic clinical syndrome in order to most probably prevent rather than to treat what is occurring. It's just a sort of consideration. Any other question? No, there's anyone.
I have a question. I would just more of a thought. I thought it was a really thought-provoking talk. I just thank you so much for that. Especially it's a good way to get the year started. Thank you.
Oh, well, thank you.
So you mentioned the Salimarin compounds, and Labor has previously published that bile acids can control bilirubin levels. And it seems like there's like a yin and a yang there, that maybe the bilirubin could potentially be regulating the bile nephropathy also. Be kind of interesting. But one of my thoughts I was thinking was, if you could treat with statins to limit the amount of cholesterol that's producing in the bile acids, could that be a potential therapy that could be very safe in the future too? Do you have any thoughts on that?
I found nothing on that, and I was looking for it. But if you just look at the typical and alternative pathways of bile acid synthesis, there are a lot of places along the way that might be helpful, but at the top there's cholesterol. So if you can reduce it, that is probably one way to help. And I have not seen, and maybe one of you or more than one have seen, if there are a series of persons with what's been considered bile acid nephropathy, or just looking at people with advanced liver disease, is there any difference in the severity in those who are chronically on statins and those who are not?
They are not. Although there are some preliminary data suggesting that the treatment with statins may decrease the portal hypertension, thus increasing the life expectancy of chronic liver disease. There are no strong data on that. We had the Yellow Seminar last September, where one of the wizards of this field, it's Amy Bosch from Barcelona, presented data on what they are doing. And apparently, they stress the idea that statins prevents the deterioration of chronic liver disease. How much it is, I have no idea. When we should start the treatment, I have no idea. So, but I think that this is open in order to try to fill the gap between what is seen on the in vitro or animal model and a much more complex setup of a patient. What is known that statin most probably is acting by increasing the production of nitrogen oxygen, thus increasing the permeability of the vascular bed. But still, I recently reviewed a review paper submitted to a journal dealing with this topic. And although I suggested to reject this paper, the paper stressed the idea that this may be a possible way to go. But again, I mean, all things are moving at the same time. Whether Salimarin is protective per se or is a sort of indirect effect is one issue. Whether bile acid, bilirubin, conjugated bilirubin, and conjugated bilirubin are acting by themselves or by indirect loops, well, it's still open. But I think it's a fascinating field to be explored. May
I have one more comment?
Yes, you are allowed.
So, in terms of possible use of statins, I think that it will not work because based on the studies by Martin Carey, it seems that biliary lipids are strictly compartmentalized. I mean, that biliary cholesterol comes from the HDL lipoprotein, whereas bile acids are derived from LDL and VLDL, but not from de novo synthesis of cholesterol. And it's also known that statins are not helping or deteriorating formation of cholesterol gallstones. And based on these indirect data, I would suggest that it will not help the bile acid-induced nephropathy. Yeah.
Well, I thank you for this discussion, which is very informative for me. And I think what I've learned in preparing this little talk for the Yellow Seminar is that bile nephropathy is an understudied area. So since I suspect it can contribute to a number of bad outcomes, whether it's independent or not, it's something that someone could really study and make a difference. So that's for the young people here.
I agree. Okay, if there's no further any other additional question, let me thank once again Julie for the excellent presentation. Was indeed a beautiful way to start the new series of the Yellow webinars, and keep safe, which is very
Yes,
important.
all of you as well, and I hope that the surges that may be coming to Italy and to here and everywhere in the world will at some point get to background, so we have endemic SARS-CoV-2 rather than pandemic with lots of death.
Most important, we can get together physically and not just in front of the screen.
That would be good.
Absolutely.
So, Happy New Year to all of you.
The same to you.
Thank you.
Thank you very much.
Okay.
Thank you so